RT Sidebar, a podcast by respiratory leaders for respiratory leaders. This is RT Sidebar, legally bald. Stay tuned. All right. We are super excited for today's episode of RT Sidebar. I am Matt Pavlichko, the Honorable Matty P for today. I have my rubber mallet, which is my gavel. I'm an idiot. We are super excited, Mike. We have an RT, Dr. Mike Sheahan is going to talk to us about the legal aspects of respiratory, which is always important. We were like, oh, that's going to go against my license. Oh, we're going to get sued. There's so much unknowns and misunderstandings about the legal aspect. So big shout out to Cedric and Rafa for getting you introduced to us so we can learn more about what you do. You have some of the coolest stories. I cannot wait. We have RT Sidebar Barflies on the line. We have Anna Hayes is here with us. JB is taking care of people because that's what he's supposed to be doing. So Mike Sheahan, welcome to the podcast. We're so super excited to have you.
Thank you. I'm happy to be here. I'm excited.
So, Mike, tell us a little bit about you. I know you're a faculty member. You do a little bit different, but then talk about what makes you a little bit different than everybody else, because you do something that's kind of cool for an RT. So go ahead.
Yeah, I do something really fun. Well, first of all, thank you for having me. I really appreciate it. I'm a program director and co-faculty chair for both a bachelor's and associate degree program in Southern California. I've been in the field for about 27 years. And in that time, I've had the opportunity to do much of what we can do in respiratory. I've never been able to do, life flight kind of stuff, which sucks. I wish I had the opportunity. But I'm lucky enough to be able to serve as an expert witness for the last about 11 years. I've been doing that. And it's something that becomes really educational. And it's something that I got into really, I did it because my dad used to do it.
Okay. Well, tell me more. I mean,
yeah, my dad was a hydrogeologist, and I can't remember the company that he was working for, but he also has his JD. So he's also a member of the California bar. Okay. Although he never practiced law. I remember him through his company, and it was really organic the way he did it. The air conditioner company Carrier, yeah. They had a groundwater case and they were being sued. And I can't remember if he was hired by Carrier or somebody else, but I remember one day seeing him sitting in his spot on the couch. And I must have been, I don't even know, 10, 12 years old. And he was reading depositions, taking notes. And I asked him what he was doing. And so that just kind of stuck with me. I'm the only kid at 12 years old that knew that there was such a thing, I guess, as an expert witness. So when I got my master's in 2008, and then I started my doctorate in 2012, I started thinking about whether or not we would need that. That was something that was necessary in respiratory. And so I approached my dad, how'd you do it? And he didn't have any good answers because his was organic and he was kind of hired through his company. But I got on some registries, and, I came up with a fee schedule. You start sending out your resume, you put it on LinkedIn, you do whatever you can to kind of advertise yourself a little bit. And I got my first case, and I'll tell you, I can't even remember what my first case was. In I think 2013, 2014, I think it was 2013. Okay. I got my first case. And since then it's been more and more regular. Some years I didn't have anything. And other years I've had 3 or 4 within the year that I've been working on. And so you got to keep track of that because I can't take notes. My notes are discoverable in court, so I have to keep it all up here.
Interesting.
So it becomes a little bit complicated, but I got into it initially because I thought, oh, that'd be something cool to do.
Mhm.
And as I started doing it, I quickly realized that no, as an educator, it's important for me to do. Because I can now take those things that I've learned into my classroom from some of these cases, and you'd be amazed at kind of what happens out there. And I've worked for both plaintiff and defense,
Uh-huh.
and it's really become to me a way to help just make sure what's right is right. And so I've worked for a plaintiff's attorney, and I've had to
Mhm.
tell them, no, 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 they didn't screw up. Everything's fine. I'm sorry. And I've worked for defense, and I've had to tell them, no, 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 you guys settle
I screwed
quick.
up.
Yeah.
Mhm.
And I've had the opportunity to play both roles, and it's really neat, you know, but what I find most important, most exciting is being able to bring that in to the educational environment with my students with regards to standard of care and from an
So
ethical standpoint.
so I'm going to do this because I just been spending all my time on sound effects today. So I'm going to do this. We need to talk about that standard of care.
All right.
What? Okay. So when we were kind of doing our thing before
Mm-hmm.
and talking, standard of care matters,
It
right?
does.
And
Absolutely.
sometimes, do we all practice that standard of care? Do we all
No,
practice? And we don't.
we
So
don't.
you were telling me a story, and I want the audience, I want our barflies to hear the story. Is minimal leak technique.
Oh yeah.
Tell us that story, because I think it gives us a lot of context about what you do, but also what we do as RT. So tell us about that story and
Sure.
get detailed. I want to hear all about it. It's
So
so cool.
I just finished a case about I was working for the plaintiff, and it was a girl who's now 27. She was 23 at the time. And when she was 23, she had a diabetic seizure, wound up intubated.
Mhm.
Um, and as a result of intubation and cuff pressure, she wound up with an A-frame stenosis at 23 years old.
Okay.
She had, go ahead.
Just what is an A-frame stenosis? So I'm a neo-peds guy. When you said that, I didn't quite like. I'm
Gotcha.
thinking like a house that's an A-frame. That's
So A-frame describes uh, the way it looks,
okay.
right?
So it's
Stenosis is simply an abnormal
Mhm.
narrowing of the trachea, and
Absolutely.
hers was down to, I think, 4 millimeters. So she had lots of trouble breathing. She wound up having to have a tracheal resection. She has a permanent uh, trach in place to
Mhm.
maintain with the stent to maintain the airway for her now. And my thing is, at 23, she had this happen. She had no other risk factors for a stenosis, and there are very few for tracheal stenosis aside from the ET tube cuff.
Mhm.
And so I started reviewing the ET tube cuff, looking for the pressures, and I had to go through, I don't know, 3,000 pages of documents. Um, and again, you got to keep all this up here. You can't take notes. Notes are discoverable. I can write a report only if I'm asked to, but a lot of times they prefer
Oh,
I don't.
okay. Mhm.
Um, so what happened was, during the intubation, the hospital policy stated that they were to do MLT or cuff pressure. So everybody did MLT because it's easier. Um, or let me say, we assume everybody did MLT because, let's be honest, in Epic, it's a checkbox. Whether you did it or not, you just check it. And interesting
Mhm.
side note, I just replied to somebody in the last couple weeks on respiratory therapy break room
Mhm.
who who um who made the statement, just check the box and move on. And I was like, whoa, whoa, whoa. And I just said, even if you're joking, that's not okay, because somebody's going to do it. And I'm saying that having had this previous experience. So
Mhm.
MLT stands for minimal leak technique,
Mhm.
right? And the way that works is that we inflate the ET tube cuff until there's a seal. And then we withdraw air until we hear just a little bit of a leak at peak inspiration. That's the way MLT works. Somebody asked, so I was answering.
Mhm.
Um, but the problem with MLT is your MLT is going to be different than my MLT, And that's even if you do it or if I do it, right? I can't guarantee. I might just be checking the box. Well, during this period of time with this girl in ICU being intubated, there was a 12-hour period where MLT wasn't even documented, which is silly if you think about it, because it is just a checkbox. And we have, res ipsa loquitur from an ethical standpoint, which is Latin for, if you didn't document it, you didn't do it. The evidence speaks for itself, is what that phrase means. And so if you documented it, I have to assume you did it. Fair is fair. I'm looking at, as an expert, I'm looking at the charts and depositions. So I have to go based off of that. I wasn't there. But if you didn't document it, then I have to assume you didn't do it. And so in these depositions, the therapist was saying, no, I did it. I always do it. And my response was, but you didn't document it. And if you didn't document it, then you obviously didn't do it. So going back to MLT has problems, because a half milliliter, where you might hear MLT, might actually increase pressure. And I found literature on the NIH that shows studies that show this. A half milliliter might increase cuff pressure by as much as 9 centimeters water pressure. And so then I had to educate the attorney that I was working for on capillary pressures and all of this other stuff, and how stenosis occurs as a result of ischemia and the sloughing and stuff. So I had to really kind of educate them so that they could then have their deposition. So I got the opportunity to play litigator also, where I was able to tell them, hey, ask this question. If they answer this, ask this. If they answer this, ask this. I didn't think they'd do it, but he actually took notes. And when I read the deposition, he had done it. And the interesting thing, and not to pat myself on the back, but the interesting thing is, after he asked the questions that I recommended he ask, the opposing attorney's respiratory expert agreed with me from then on.
Yeah, and 100%.
And shortly after, they settled the case. Yeah.
Yeah. So Anna, MLT, when we're with the cuff, right? So think about it as a healthcare acquired pressure injury in their trachea. That's the way I look at it. But it's been out of favor
since 2006.
Yeah, for a long time. But I'm looking at Rob. I know Jonathan, Mike. You get to see places like it's very popular still. Would you agree?
It is. It is very popular still. And the problem is that the policy at the hospital said MLT or cuff pressure. So everyone did MLT. And we as therapists have a responsibility to maintain standard of care. And standard of care, there's the definition, which is what would a reasonably trained, well-qualified therapist do under the same circumstances. That's how attorneys look at it. But I also look at it as standard of care is the minimum bar. And if cuff pressure is the minimum bar and MLT is below standard, then every therapist that did MLT on this girl who wound up with that A-frame stenosis is substandard. And the director of the department for allowing that policy to stay in place is substandard. And so I went up and down the line with it.
Yeah, but so let's talk about that for a second. All right.
Sure.
Many RTs, including me. Hey, I followed hospital policy. Not me.
Yeah, hospital
I'm
policy
not to blame.
Not enough.
So talk about that. So who was to blame, and what happened? Like, what happened?
So in my opinion, in my professional opinion, and I guess expert opinion, go figure, everybody was to blame. So I in my deposition, when I was asked, they asked me, so was this therapist's fault? And I said, yes. And they said, was anybody else at fault? And I said, yes. And they acted shocked. And they said, well, who else could be at fault for doing this? And so I said, the director, who's responsible for the departmental policies, administration, who's responsible for hiring an appropriate director, right? Everybody up and down the line, the therapists themselves who should have known the minimum standard was cuff pressure, because they all graduated after 2012.
Yeah.
right? So they should have known, and the director, being a director, should have been educated. That's why we do continuing education, right? All of these people should have known that that was not good enough and we needed to do better. And that's what it becomes. It becomes we
Yeah.
need to do better. And that's what I love about doing this expert witness stuff.
So what Caroline said, she just asked, if there wasn't a manometer available, leaving a note or something in it, that from what you're saying is probably not enough because it's still not doing the standard of care. There can't be excuses to it, right? Because then somebody would be liable for not meeting that standard, correct?
Um, no, you're
Okay.
still
There you go.
responsible.
Yeah, you're still responsible.
The answer is you're still responsible. So if you so to answer the question, when you don't have a cuff manometer available, a note will be enough. No, go get the cuff manometer. Hospital's responsible for this, right? Hospital should, and the director should go to the hospital administration and say, I need this, right? We have a budget for supplies. This is an important
Of
supply. We
course.
got to get it. Here's why we got to get it, right? Here's the literature. Here's why we need it, right? So
Mhm.
that's simply not enough. And as a therapist, the next question, which I think is interesting, right? To cover the therapist but what would the therapist, what the therapist would do is the therapist wouldn't necessarily be at fault. And so let's talk about that for a second,
Yeah, let's talk
because
about that.
so the therapist who's following the hospital policy, while in my opinion, right, as a respiratory therapist, we have a duty to that patient. We have a
Mhm.
duty to care for that patient and maintain, and actually not just maintain, but deliver care that's above the standard of care.
Mhm.
We need to go above and beyond, right? People think, people clock in and clock out all the time. And we don't truly care for our patients. We view it as a job. And that's the wrong view. And I've actually told people on respiratory therapy break room that if that's why you're here, if you're here for the paycheck, you're in the wrong profession. You shouldn't be in healthcare for a paycheck. And I say that knowing that there was a time that it was a paycheck to me, you know, but
Sure.
but because of that, I take it personal. Um, so I'm sorry, I'm on top of my soapbox.
No,
But
no, no worries at
to go
all.
back to Caroline's question, right? When the hospital is sued, it's not the therapist that's sued. It's the hospital that's sued. When you work in a hospital, you're covered under the hospital's liability insurance.
Mhm.
Now, if you screw up and the hospital isn't at fault, you're probably going to get fired. I would imagine.
Mhm.
I've never had that happen. I won't say I never screwed up, but I've never been fired, but I would imagine that's going to be the case. If, however, the hospital is responsible and for some reason said, no, you cannot have a cuff manometer. And I don't know a hospital that doesn't have a cuff manometer. Even the smallest hospitals have cuff manometers, right? But if that were the case, I would imagine the hospital, the therapist would have a wrongful termination suit maybe against the hospital for not
Sure.
providing standard equipment, standard of care level equipment. So that would be my answer to that.
I think
Unfortunately, I've been places where it wasn't available. Oh, wow. So I've never have been. And
I have.
so,
Yeah, I
yeah,
have.
in that case, that would be something of concern for me personally,
Mhm.
because I have a responsibility to my patient. And so
So,
I look at it
yeah.
that way.
So one of the things, Mike, that you brought up, and legal, ethical, moral values, they all kind of intertwine a little
Yeah.
bit. But the one thing that you said that really stuck with me is if you're doing the right thing, you're probably pretty good.
Yeah,
And if
for
you
sure.
always keep that, hey, I'm going to do the right thing for my patients, the hospital, for my community. If you do those things, and everybody up and down the line does those things, you're probably okay. Talk about
Yeah.
that because I hear
I,
I
and I
hear this
would,
all the time. It's going against my license. I'm not taking that student, or I'm not doing this because it's going to be against my license. I don't think that's how that works. So talk to
no,
me a little bit
it's
about that.
not. And nurses say that a lot too. And I don't know if that's true for them or not either.
Mhm.
But it's not, it's really interesting. So we have to talk about different aspects of the moral decisions we make, right?
Yes.
And that's part of the ethical discussion. So in ethics, when I'm teaching ethics, I'm not teaching ethics, by the way, I'm discussing ethics with my students, right? We can't indoctrinate. If we indoctrinate ethics, then we're not doing any good. We have to discuss ethics because one of the things to keep in mind is that even though you're doing it right, if I disagree, it doesn't mean you're wrong. What that means is we have role duty, we have consequentialism, right? And just with those two, right? So consequentialism is, what does it mean? What's the result? Does the result justify the action regardless of my role? And sometimes it doesn't. And I'll give you an example. So let's say you're in a hospital where you've come from a hospital where, and I had this happen, you've come from a hospital where you intubate everybody. When I lived in New Jersey, we did all in-house intubations. I've intubated hundreds of adult ped and neo patients. And then I moved to California. And when I moved back to California, I worked in a hospital where we were not allowed, per hospital policy, to intubate. What if a patient needed to be intubated and the doctor wasn't there? Now, the rules, which is role duty, say I can't do it. Consequentialism says I must do it because I'm capable, I'm qualified, it's within my scope at a federal level anyway, and I can do it, and it'll help the patient. If I don't do anything, the patient dies. That's consequentialism, right? So we fall in these different categories. You might fall more towards a role duty. I might fall more towards consequentialism. Which one of us is more right? The answer is neither. We just have, and there's about 4 or 5 of these different aspects that we deal with, these legal and moral, or I'm sorry, ethical and moral aspects that we're playing with all the time. You come up to a yellow light. Do you speed up or do you slow down? The question you're supposed to ask is, can I stop? But what's the question we actually ask? Can I make it? Yeah, can I make it?
Exactly right.
Right?
No, but that makes complete sense because, everybody looks at legal, ethical, more everything. It's black and white. It's either right or wrong.
And
But
it's not.
it's not like that.
Right.
And I just want to tell a quick story because I had that exact thing happen about intubation. I was working at a small community hospital and I got called in the middle of the night. They had a baby that was just delivered. And I'm sitting there going, well, they didn't know what to do. It was a premature kid. And my background's NICU. So they called me in, the therapist, hey, we are very uncomfortable. Managers, I go, bag, I live 5 minutes away. I'll be there. I get there and they're like, well, this child needs to be intubated. And the doctor says, I'm not comfortable. And I said very specifically in the moment, I go, I can be your hands, but you have to order it for me to do. Because legally, or based on the role, I am not allowed to do that here. Even though I've done it hundreds and hundreds of times at other hospitals, you are role-wise allowed to do this and don't feel comfortable, but are consequentially, you're supposed to do it.
Right.
The opposite is for me. So putting the two in the child was the right thing to do, but if you look at it, it's very gray.
Yeah,
and it was so it was uncomfortable. Now we got the tube in, everything was great, and everybody kind of understood. But did I have a little talking to the next day? Yeah, I did.
Right.
We had to go through it.
So now go back to the licensing question. Is my license on the line?
Okay.
Well, to answer that question, it's an easy answer, but to answer that question, you have to look at our scope of practice, federally, state, and then from a federal perspective, state perspective, and hospital perspective. Because what the federal scope of practice says is we can do all this stuff. And then they say, we'll leave it to the state to minimize from there. And then the state leaves it to the hospital.
Yes.
Right. So in that situation, the hospital could have chosen to contact the respiratory care board and file a complaint because you were outside your role. And had something happened, I promise you they would have, because they're all about their dollars and cents.
Of course.
And they're going to protect themselves first. So thank God nothing happened. I'm glad you did the right thing. You know what I mean? But in reality, had you been a person who was not capable, but thought you probably were, and tried and failed and something happened, you could have been in trouble. And so
Mhm.
sometimes in times like that, our license is on the line. But giving albuterol, no, your license isn't on the line. You're all right. Give some albuterol. Give it to the CHF patient, whatever. It's fine. You know what I mean? You're going to be okay. So it really depends on the situation. So we go back and forth between role duty and consequentialism all the time.
But the consequentialism of giving albuterol to your CHF patient is wrong. It's wrong.
But you're not going to hurt them. You really aren't.
There's no consequence to it.
Yeah, there's no
Consequentialism.
negative consequence.
Bingo.
And so you hear that wheezing, you know it's CHF. We assume that's fluid, of course. But what if it's not? Is that treatment going to hurt them? No, no, no. Sometimes it's a psychological treatment we're giving. Sometimes it's for the patient. Sometimes it's for the doctor or the nurse. And a lot of times we want to argue it. We want to spend more time arguing it, trying to educate them, which isn't a wrong thing to do. But I feel some people look at it and go, well, that's just work I shouldn't have to do. And I look at that and say, that's the wrong statement.
Why is that?
Because we work in patient care, not patient don't give a crap. So if we're caring for the patient,
Interesting.
we look at certain things and we say, you know what? I don't think this patient needs CPT. I don't think the COPD patient needs to be woken up at 3, but the COPD patient wants to be woken up at 3. I'm gonna wake him up at 3. Why? Patient care. It makes him feel better. Then I'm caring. And so everything we need to do, and this goes back to standard of care, it needs to be based on patient care. Everything we do has to be directly related to caring for the patient.
So this could get into interesting discussion.
Sure.
Because yeah, I agree. Giving is, and Rob wrote it down, whether it's albuterol or anything, giving the right drug to the right patient is what we should be doing.
And I absolutely agree with that statement. I won't argue against that statement.
Mm-hmm.
What I'm saying is there's a time to educate the nurse and doctor. In the middle of it is not the time. That's my personal opinion. So what I'll do is, knowing that this patient's ordered this treatment, I'm going to go ahead and give it. I don't believe it's going to help. I'm going to give it, makes the patient happy, makes the nurse happy, makes the doctor happy. Now I can talk to the doctor and advocate for my patient's care.
Okay.
But there's a camaraderie that we have to maintain. And we have to remember that other people see what you're doing and they don't always take it the way you mean it. So while you're there trying to educate the doctor and you have a good rapport with the doctor so you can argue, another therapist who doesn't have the same rapport is going to potentially think that might be okay. And they're going to take a stance, and it could be for a different reason. What I have to do is I have to be responsible to my field. I have to be responsible to my patient first, but I have to be responsible to my field.
Okay. So I have questions.
I don't disagree. I don't disagree with Robert's statement. Not at all. I wouldn't argue that at all because I agree 100% with him. But I also feel that we have to sometimes put our personal feelings aside in a particular situation.
Mm-hmm. We've all seen therapists. Gets a call, beeper goes off. I've been doing this too long, so yeah, we saw beeper. Beeper goes off. You call them back, and they're like, "Hey, this patient needs a breathing treatment." You know they're there for CHF. You know they're there for a broken toe, and you're arguing on the phone about seeing this patient. Because I'm going to get to Jonathan's in just a second because we are short staffed. Let's just be honest. That's what we are. We're short staffed. We don't have the resources to see everybody, so we look at that as taking away from what we should be doing. But Mike, you and I've talked about this a little bit. It's not the treatment that's the value. It's the respiratory therapist's eyes on that patient.
Yes.
That's the value.
Whether you give the treatment or not, go to the room.
Go to the room, right? Yep. So if you're going to see that patient and you're like, oh crap, they need Lasix, at least you saw them and said, hey, tell the doctor to order Lasix. Like, that's not advocating for your patient or your profession. So
along those lines, you go to that patient's room, you see that the patient needs Lasix. what I do is, I'm not giving propofol. I'm giving albuterol. So we really have to class it out that way. And this goes back to Robert disagreeing with my stance. We have to class it out that way. What I will say, what I have said is, look, the patient's a CHF patient. Patient's got fluid. I can hear the fluid. I can hear the rails. I can hear everything going on. I can give the treatment, but it's not going to help. Ask the doctor for Lasix. And at that point, the nurse can make the decision, or the doctor, if the doctor's in the room, I will explain to the doctor what's going on. But we have to know how to speak to a doctor. We have to make sure the doctor knows that we know what we're talking about. So we have to be educational. One of the main things we do in our field is education to patients, to nurses, to doctors, to prospective therapists, right? That's what we do.
That's what we do.
And we have to keep that in mind. And so how many times have you heard, oh, finally we're friends?
I love it.
How many times have you heard a nurse or a therapist go in and a patient questioned why they're getting something, and the answer was because the doctor ordered it? That's the wrong answer. If you don't know, figure it out, find out, learn. You should know. You should know why the patient's getting the treatment they're getting, and you should be able to tell them if you agree or disagree. So go back to the CHF patient. If they ask me, why am I getting albuterol? I have CHF. I'm going to soften it for the patient, but I'm going to let them know that I don't necessarily agree with it, but we're working on getting some Lasix. In the meantime, let's see if this helps.
Okay.
You know what I mean?
I think that because once again, you're going back to doing the right thing for the patient. If you do the right thing for patient care, you're probably good to go.
For sure. And if you take that to the, not to the extreme, but to the next step, that I'm always trying to do a little bit better, right? So we have non-maleficence and then beneficence. Non-maleficence is do no harm, but beneficence is be of benefit. So yeah, non-maleficence is good. Don't hurt the patient, but you should take that one step further, and everything you do should be for the patient.
Yes.
I worry a lot of times, and I know I'm very confrontational about it, and I apologize.
No.
I worry a lot of times that therapists are working to go on break. That's the goal, right? I mean, let's be honest. Everybody on here who's a therapist, you know which room has the quietest area, right? We know which waiting room is the coldest on a hot day. We know which bathroom is the most secluded and cleanest bathroom to use. We know all these things in the hospital we work in. But we got to care for the patients first. There are times where we don't have time for a break. And so somebody asked a triage question, and I wanted to get to that. When I worked in New Jersey, I worked in a hospital. It was like a 350 bed hospital. It wasn't a huge hospital. But we had two therapists on night shift. One had ICU and telemetry, and the other had the rest of the hospital, including ER. And there were nights where I would have ER in the middle of summer in New Jersey, where everybody's coming down to the shore and they forgot their meds, so they're all wheezing. And so you have a busy ER in the summer, which is odd in California. We don't get too busy in the summer, but in where I lived in Jersey, you did.
In Jersey, you do. Yep.
Yeah. And so we would have a busy ER, and I'd have 50 Q4 around the clock treatments because the doctors refused to change them, even no matter how I advocated, right? So I'd be in ER, and one night I had a code in ER, and that night I had 50 Q4s on the floors, a busy ER, and the therapist in ICU, who would normally come help me, had 17 vents and 25 Q4s in telemetry.
Oh my God.
So he was unable to help me. So I was by myself in ER. I had to triage all the treatments up on 3rd and 4th floor because I was busy in ER. I had to document that I was busy and that I wasn't able to get to them, right? And this was before DRGs. So this was back before diagnosis-related groups from insurance companies. So they wanted me to bill for everything. And so I actually got written up because I didn't do the treatments that I couldn't get to. But there are times where you do have to triage when you're short staffed, and you have to figure out, okay, who really needs it, who doesn't. And that's where we have to be able to assess. And that's where patient care, again, comes back into play.
Whoa. Whoa. Getting written up because you missed 50 treatments?
Yep. I missed the 3 a.m. treatments.
Holy crap.
Because I was busy doing compressions for 2.5 hours.
Wow.
Oh yeah.
I know a lot of the people here, Rob, Jonathan, Caroline, myself, all respiratory therapy leaders at one point. Can you even fathom that?
No, I did it, and I still can't fathom it. Yeah.
The first thing should be out of any leader's mouth for that is sorry.
Oh, for sure.
Sorry. And things were different back in the day. I worked back in the day before DRGs too. But holy crap, what a horrible day.
Oh yeah, it was rough. And there were nights, and then there were nights where with two of us, we had nothing to do except try our best not to fall asleep. And I wasn't a sleeper on nights. I never slept. I wouldn't do it. It freaked me out. But
oh yeah,
we had nights where you have nothing but a break. And then you have nights where you get no break, and they even themselves out. That was kind of my point in the story. They even themselves out. So we shouldn't be working toward a break. We should be working for our patients and understanding that, hey, if honestly, and I hate to say it this way, but if this job isn't right for me, if this career isn't right for me, it's right for somebody else. That's somebody's mom, somebody's dad, somebody's brother, sister, son, daughter. And if I cared for your mom the way that you're caring for that patient right now, how would you feel?
Yeah.
Right. You have to step outside. Right. So I talk a lot lately about perception versus perspective. That's been a big thing for me. And I can't tell you why yet. I'll tell you why as soon as I'm allowed to. I'll email you and let you know.
There you go. All right.
But it's been a big thing for me lately. And we often live in our own limited little viewpoint. And it's very subjective. But patient care, we need to be objective. We need to change our perspective to what does the patient need? What would I want if that was my family member? What would I want for them? I'm going to do that, and that's kind of how it needs to be approached.
Do you think it's hard for therapists today, especially after COVID? Because we always say that, right? Think of it as your grandmother in the bed. We've been saying that since the cows come home. We always say that. Have we forgotten that?
I don't know. I don't know that we've forgotten it. I don't know that. I think there are people that feel that way, and there are people that don't. And I tell, that it's funny because I talk about, and maybe this is unrelated, but it just popped into my head. So I'm gonna pretend it is. We talk about, so-and-so loves ER and hates being on 4th floor, but then there's, so-and-so over here that hates ER or loves to be in ER. You got one that loves ER, hates 4th floor. You got one that loves 4th floor, hates ER. I say, put the guy that loves 4th floor up on 4th floor. He's going to do the best job. Let him do it. If you got somebody like that, let him go. A lot of times we love ER because we love the adrenaline that we feel like we're going to get in ER, right? But that can lead to burnout, and that's fine. That person who loves ER eventually is probably going to want 4th floor. And when they do, let them go. Let them have it. Because we do better where we prefer to work. It's when we don't prefer to work is when it becomes a problem. And that's when that ethical and moral dilemma really comes into play. That's when we start to make mistakes. When we're working to get to break. We're trying to get there and get everything done as quickly as possible. That's when we start to make mistakes. We start to miss things. We start to slip. And if we're thinking of the patient first and foremost, then we're going to do better. And that's what it's all about.
Yeah. And, we always tell RT Sidebar is a podcast by respiratory leaders for respiratory leaders. And if we care about patient care, let's really care about it. but let's care about the people that are delivering patient care. That's what leadership's about.
Absolutely.
Because if that leader's doing the right thing, the therapist has the best chance to do the right thing. And when that happens, then your risk of any type of litigation goes down considerably. It's the right thing to do. It's the ethical thing to do. It's the moral thing to do, but it's also the legal thing to do. And I think that's really where this all comes up. Caroline just put in the chat, which I'm so glad that she did. Caroline and I met with future RT Sidebar guests to talk about professionalism, talk about the why, what brings you to the table. You teach students, reminding them of the why is what makes them good, but it also brings their standard of care where it belongs. And not trying to get done as fast as you can to get to that break room. So, I mean, this is fantastic discussion. I would love to discuss one topic with you in the future because it would open a can of worms like there's no tomorrow.
Sure.
As you live in California,
Mhm.
nurse to patient ratios, therapist to patient ratios.
Oh, yeah.
All of that stuff. It's for another time. But I think, Mike, I think you coming around every once in a while and talking about one of these hot topics will go a long way. We get Rob in to throw in some ethical considerations. I think that this is a potential like legal snack. I got my gavel.
No, I'd be happy to.
I got my gavel. We're good to go. So
I'd love to.
That would be awesome. So it's time to finish up. We're going to open it up to questions, but I want to get to shout outs. I really want to talk about some of the things that are coming up. Mike, for your final thoughts, what are a couple things all respiratory therapists should keep in their mind when it comes to the legal aspect of their care?
So for the legal aspect of their care, if you are very simply focused on the patient and your goal is to reduce ventilator days, reduce hospital length of stay, right? Improve the condition of the patient. If those are your goals, you're going to be fine. But you have to remain focused on those goals while you're in the hospital. It's not a clock in and clock out job, right? I'm not a barista at Starbucks. No offense to baristas at Starbucks, right? My fiance's sons are, so no offense, but this is a different line of work. It just is. It's not, you're not working at Macy's folding clothes. There are certain jobs that are clock in and clock out. This is not one of them. And we often treat it as a job. We don't treat it as a profession. And treating it as a profession is important. And what that means is getting involved in being better, helping those around you be better with education, bringing as much as you can into that department so that everybody can grow together, because we're never done growing. So that would be my final thought with regards to it. When it comes to protecting yourself legally, if you're focused on patient care, you're going to be okay. But you have to be focused on patient care as a professional.
I love that. And as a profession, my shout out to get us started. Thank you so much, Mike. My shout out to Maria Madden down at the University of Maryland Medical Center, who's going to be coming on soon to talk about professionalism. It's a great segue into what you're talking about, the ethics conversation. Rob, you talked about servant leadership. Like we've talked about a lot of different things that all kinds to starts to merge together. So Maria coming on, shout out to you. Thank you for your hospitality with Caroline and we're looking forward to it. Mike, shout outs.
I have too many, I'm sure. I first and foremost, my fiance and my daughter, who are both on today supporting me. And I think that's the sweetest thing. I know my daughter's at work right now, so shh, don't talk about it. But really my fiance, my kids, all of them, they make me want to be better. And I've not always been as good as I am today, and I'm not as good today as I hope to be tomorrow. And that's a result of them just being, they make you want to do more and want to be a better person. So, I got a heart from my fiance.
Oh, wanting to say gave you a heart. That's so sweet.
So, and then I shout out to my team at Crafton Hills College. Without them, our program would be nothing. My program doesn't rest on me. I'm the leader, but they provide everything. Our program is in the top 10%.
Mhm.
And we get better every single year. We are one of the best programs, I think, in California. And everybody that came on today, I really appreciate that. That's really awesome. I didn't realize that it was actually going to have people on until I reread the email, or until I went to register, and then I realized, oh no, I got to do this in front of people, because I'm not a public speaker. I know I'm a teacher. I teach in the classroom, but I get nervous still. I've been teaching for 21 years, and I still get nervous every time I walk in the classroom.
Yeah.
But, and then of course, you guys, I really appreciate you guys allowing me to do
you.
this. This is awesome. This is a blessing for me. And I would love to come back. And then of course, Raf for setting this up.
Yeah,
I've known
absolutely.
Raf since 2007. We both used to work at the same hospital for a period of time.
That's awesome.
And he's just, he's been super cool making this happen. So I appreciate that. That's a killer friendship to have.
That is awesome. Before I go, Anna, any
Oh,
shout
I'm
outs for
sorry.
you? Oh, go ahead, please, Mike. Please
I
go
guess
ahead.
I guess I should, my dad and my mom, of course, for, helping me be this, and, giving me good examples. I didn't always look at them, but I do now. I was a horrible kid. But so I guess I should definitely not forget to shout out my parents.
That's awesome. Anna, do you have any shout outs? So great to
Yeah,
see you
yeah.
today.
We'll have to have you back on. Like, this was an
It's
awesome
fun.
episode, and I have a feeling like we're gonna have a lot of questions. Also join the Barfly LinkedIn group. I'm not sure if you're in it, but I think that would be a really good place if Barfly has
Absolutely.
questions to ask it directly to you. And that'll be linked in the show notes. Big happy birthday to Caleb Adams, who's a longtime Barfly.
Yes.
And happy birthday to Jennifer Amos and Dr. Whittle.
Yeah, J Dubs just had a birthday a couple days ago. So that's awesome. Thank you, Anna. JB, I know you're busy. I'm not going to ask you, but I want to say thank you to all of the Barflies, all the people on LinkedIn, Respiratory Therapy Break Room, keeping the conversation going. Rob Fishwick for poking the bear with compact licensure a little bit. We love that. We appreciate it. But we have a couple interesting announcements next Tuesday, 10 o'clock Eastern, the night shift webinar specifically for nights. Get your crappy food. Take a break from your weird patients. You're going to be a webinar just for you. We have the 3 PIs for the HyperAct trial, but it is seriously just for you. Anna Hayes, thank you so much for setting that up to half of our respiratory therapists that work night shifts. So thank you so much for doing that. It's something new on RT Sidebar. Keep an eye out on LinkedIn, all of your different socials. We have Maria Madden coming on. We have the asthma lady, Linda Nozart's coming on with a couple of our asthma educators from Eisenhower. Anna has a very special guest, Jessica, that she finished recording yesterday. And it's all a big surprise. I can't hear it. I'm so excited, Anna. But one of the best storytellers I've ever met in my entire life. We have such good things going on. JB, you and I have our snack that we just recorded. So great things going on at RT Sidebar. Join the Barfly group. Everybody get involved. Be the best that you can be for those patients. So thank you so much. Any last comments before we go?
Would it be okay if I quickly plugged my book that we were talking about?
Yes,
That'd
you
be cool.
can. Yes, you can.
So-
Please, my friend.
So I am a first-time author. I just published my first book. It has nothing to do with respiratory therapy. It's available on Amazon. And it's kind of morbid, but a quick background. In
Please do.
1987, when I was 12 years old, my grandmother was murdered. And in 2003, they found the guy using DNA. And I went to the trial. And so took me 20 years to write the book, to get the book finished. I had to wait to get transcripts. But I just finished and just published the book this last week. And it's called 10 Feet from a Killer, a True Account. And So I appreciate you letting me plug that. I'm really excited about it. It's dedicated to my grandmother, but it's largely about the development and growth of DNA over the years.
That is so awesome. Mike, thank you so much for your time today.
Thank you.
We're going to plug the crap out of it. Barflies, I'm challenging all of you. Get 10 feet from a killer. Tell all of your friends. I'm downloading it
I appreciate
now.
it.
So
Thank you
it's going to
so
be
much.
awesome. I can see Anna's looking for it right now. too.
I just found
So-
it, so it'll be linked in the show notes, so you can.
Awesome. Thank you so much.
No, congrats, and wow, what a crazy story. I guess Barflies, give us some feedback. Maybe we need to have a book club and book review. Have you back on to talk about it.
That would
Oh,
be
I would
so awesome.
love to. I would love reviews.
Honestly,
Yeah.
I think, Michael, a lot of people are going to ask questions of how did you become an expert witness? What's that like as a side hobby, not a side hobby, but side, I don't want to say hustle here, but like if someone's interested and wants to do it as well.
Yeah.
And then to be a published author, I'm sure there's so many barflies who would like to also publish, and how you went about that process. And I feel like many doctors write novels and books about COVID especially, and I don't know if one by an RT, and I think that would be great if you could talk about that process sometime.
Sure. I'd
That'd
be
be
happy
awesome.
to.
All right. Well, we're going to finish up this episode. We're going to stay on for a little question and answer when we're all done. Mike, thank you again for everything. But there's so much opportunity, so much more to talk about. As we finish up, you get to hear from our lovely producer, Anna.
Thank you guys so much for having me. I appreciate it.
Everyone, stay tuned and have a great.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Ped Litchfield and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.